In this session, we will explore the pathophysiology, clinical features, and treatment of hypothermia. At the end of this lecture, you will be able to define hypothermia and its classification, describe the pathophysiology of hypothermia, discuss the clinical features, and outline the approach to treatment. So you may wish to pause the video at this point and just consider what your definition of hypothermia is. Here is one definition of hypothermia, which is described as a state in which the body's mechanisms for temperature regulation is overwhelmed in the face of a cold stressor. Hypothermia itself may be classified as accidental, intentional, primary or secondary, or by the degree of hypothermia, and severity can be classified according to the core temperature. When we're thinking about hypothermia, we need to have an idea of how temperature homeostasis works. And there are three main components of temperature homeostasis: heat production, temperature control, and heat loss. Heat production is a normal byproduct of all the metabolic processes of the body. And in fact, once this heat is produced, the work of the body is then to get rid of excess heat and maintain a steady core temperature. The regulation of that core temperature is set in the thermoregulatory center in the brainstem, but also impacted on by neurohumoral and autonomic responses. For example, the autonomic system may control subcutaneous vascular tone, vasoconstriction or vasodilation, and therefore blood flow, and it may also regulate sweating, whereas the neurohumoral component may affect heat production and heat loss through the regulation of anabolic and catabolic hormones, such as insulin on the one hand versus adrenaline, glucocorticoids, thyroxine, etc. Temperature is mostly lost through radiation of heat, and this depends on a suitable ambient temperature and humidity. But it can also be affected by convection, so a cold wind and a wind chill factor can greatly increase the amount of heat loss in a cold environment, evaporation, and even conductive loss. So how do these factors cause hypothermia? Well, again, if we take those categories from the last slide, we can think of hypothermia as being caused by decreased heat production, increased heat loss, or loss of thermoregulation. A decrease in the hormones that promote metabolic activity in the body, which would include thyroid hormone, glucocorticoid hormones, will decrease metabolism and therefore decrease heat production. So hormonal conditions such as hypopituitarism, hypothyroidism, and hypoadrenalism. In patients who may be hypothermic for other reasons, as we will discuss, malnutrition and hypoglycemia may promote this hypothermia because the body lacks nutrients to generate the metabolic processes that generate heat production. There may also be increased heat loss from environmental factors, and this can be divided into inertial hypothermia and non-inertial hypothermia. induced and inappropriate vasodilation as seen in certain drugs and toxins, including alcohol, and in sepsis, or the loss of skin integrity in some skin conditions such as erythroderma or extensive burns. Finally, thermoregulation may be lost due to intracranial lesions such as strokes, intracranial bleeds, or head injuries. Drugs and toxins, for example, sedatives and hypnotic drugs, or alcohol, and some iatrogenic causes, again usually related to drug-induced comas and other side effects of medication. The cooling of the body tends to affect all the systems, but some of the more profound effects are seen in the cardiovascular, central nervous system, and of course we need to consider the local effects as well. So in all cells, hypothermia causes decreased metabolic activity. And in the cardiovascular system, that particularly affects the conducting tissues of the heart, leading to bradycardia, but in profound hypothermia, patients may develop malignant tachyarrhythmias such as atrial or ventricular tachycardia and fibrillation. Hypotension can also be seen in the hypothermic patient, partly due to decreased myocardial contractility. In the hypothermic patient, they often have decreased mentation for the same reason that there's decreased metabolic activity in the cells of the CNS, and decreased oxygen consumption. And this is thought to be one of the ways in which hypothermia may protect the brain from hypoxic brain injury. So, for example, post-cardiac arrest temperature regulation is based on this assumption. ECGs become abnormal as the temperature continues to drop. And in fact, in profound hypothermia, the EEG activity, the ECG activity, and respiratory and other involuntary movements may all cease. So the profoundly hypothermic patient may mimic death. Local effects are due to freezing of the extracellular fluid, due to disruption of tissues due to ice crystal formation, intracellular damage, and then indirect tissue damage from vascular and ischemic injuries. These patients often present with cold, ischemic peripheries and often develop severe pain and swelling on rewarming. There's a spectrum of presentation from mild to severe hypothermia. Mild patients tend to be attempting compensation, so although their mentation may have slowed down, they will shiver and present with tachypnea, tachycardia, and attempts at compensation, including vasoconstriction. In moderate hypothermia, the shivering stops, the mental status reduces further to lethargy and stupor. Breathing slows, heart rate slows, patients become hypotensive, and at the lower end of the moderate scale, arrhythmias such as ventricular fibrillation or atrial fibrillation may develop. And finally, in severe hypothermia, the patients develop coma, may have pulmonary edema, are often apneic, hypotensive with no palpable pulse, and this state mimics death even in the EEG. Bloods would include a blood gas. The classic ideas about correction of the blood gas for the blood temperature are no longer thought to be necessary. Serum biochemistry, including renal and liver function tests, blood count, and blood cultures. Chest X-rays may be useful in identifying pulmonary edema, and belt-trad ultrasonography may help us detect any cardiac activity and look at the degree of filling of the IVC to help us estimate the need for IV fluid resuscitation. ECGs may show severe bradycardia, arrhythmias, and J waves, although J waves are no longer thought to be pathognomonic of hypothermia. Again, spend a few minutes thinking about how you would treat a patient with hypothermia, and then we'll proceed with the lecture. You may want to pause the video. So pre-hospital care consists of preventing heat loss, rewarming the patient, and preventing arrhythmias. Remember, we need to remove wet clothing, place the patient in a reflective blanket to decrease radiant heat loss, and remove from the cold environment. Rewarming the patient may consist of active external rewarming, such as warm packs in the axillae and groins, and preventing arrhythmias requires gentle handling, avoiding unnecessary trauma, and consideration of any invasive procedures such as endotracheal intubation, which some authorities think might precipitate a ventricular fibrillation, although this is not clear-cut. In the emergency department, again, we think about preventing heat loss, warming the patient, providing targeted supportive treatment. As with the pre-hospital setting, we think about removing wet clothing and use of a reflective blanket. Active external rewarming may be applied by a warm air blanket such as a bear hugger. Active internal rewarming may also be attempted using bladder irrigation, pleural cavity irrigation, peritoneal cavity irrigation, or nasogastric irrigation with warm crystalloid fluids. This is really only used for profound hypothermia. Targeted supportive treatment would include airway management as necessary, ventilatory support, fluid resuscitation with warm fluids, gentle handling, and monitoring for and correcting metabolic abnormalities. These patients are prone to hypoglycemia and hyperkalemia, and in addition, some of the underlying causes may need treatment, such as hypothyroidism, hypoadrenalism, and hypopituitarism, and also the management of toxic overdoses, such as sedative hypnotics and alcohol. If you have any questions, you may post them on our WhatsApp group or bring them up on our Wednesday classes. In summary, we talked about the pathophysiology and clinical features of hypothermia, as well as the key principles behind management, including prevention of further heat loss, rewarming, gentle handling, and supportive treatment.